Okay. Okay, so basically, I am trying that few basic concept we can go through. I'm going to go fast because a lot of things you must be knowing. If you feel some of the things we need to go, I will quickly explain you. Okay, so we do have a I'm working with the company called ND Health, and I'm collaborating them with them because I don't program myself. I have
Mm-hmm.
concept and other things. So this is my disclosure.
Mm-hmm.
Now we are going to talk what is excess bonus, how the we calculate the excess bonus, how it can impact our, like for example, financial thing, what are the benefit and challenge, how to get more excess bonus. There are too many calculations the way we do it. So I want to
Mm-hmm.
make more process efficient. Okay. This is one of the slide which we need to understand because this is how my concept is that first of all, I want to say that RCP file we get from ministry is a PDF file. We just read it.
Mm-hmm.
I used to
Mm-hmm. Yeah.
do earlier, read it and do manually.
Mm-hmm.
Another file we get RCX file, which we can
Mm-hmm.
convert to the data.
Mm-hmm.
Now, rostered patient means any patient which is rostered with Ministry of Health.
Mm-hmm.
In the same, if we have with them like relationship, then other group is called fee for service. So some of them, like if going frequently outside, I still we have a relationship with them, but I like say them that fee for service or non-roster. Then third thing is termination. Termination is obvious. If somebody is signed with another doctor, code 91, they are terminated. So left side, I said terminated patient, they go in trash box. I don't worry about them. But in my Oscar, I want to make sure that my Oscar shows that they are no longer my patient. Uh, okay, so Dr. Malti has come. Okay, good. Dr. Malti, just we started, so you are not too late.
Okay, thank you, Dr. Devan.
Okay, okay. Now I just say that how capitation fee means network fee plus comprehensive care fee. Everybody know. I also in my EMR. So which EMR you are using? Everos?
I'm using Juno, which is a modified version of Oscar.
Okay, okay. So in my EMR, these are the thing field I'm using. What is the roster status? Which
Mm-hmm.
should be
Yes, yeah.
rostered,
Mm-hmm.
not rostered or terminated. These are the three
Mm-hmm.
things I just do it. I usually have a two provider. I don't know how other people are doing, but for this program to work, we need to have two provider. So one provider, like for my name, there is
Mm-hmm.
no group number. This is fee for service. So
Mm-hmm.
report by template, I immediately can filter, oh, who are my fee for service, but still they are my patient. Okay.
Mm-hmm.
Second
Mm-hmm.
group is FHO, which is in my group BAC8. So that provider, if it is in my Oscar demographic, I can know that these people are rostered with the ministry. But both group are rostered. Okay. Now, for example, I have given here example that if suppose I have 1,500 patient and there are 1,200 patient which are rostered with the Ministry of Health and 300 patient, for example, are not rostered. Now, most of the time, the idea is that we can roster, de-roster, this process keeps on going and we
Mm-hmm.
can maximize our excess bonus.
Mm-hmm.
Okay. Second concept is that even if we de-roster, I have two type of patient. For example, one patient where I say, oh, this patient, I can educate them
Mm-hmm.
and they can be re-rostered. And second group is that where I say how much I teach them, they will go outside. I
Mm-hmm.
cannot fire them, so I do not roster. Okay.
Fair.
So all
Yeah.
these things we do in our Oscar. Okay. Now this is simple concept which I made like a pie chart where we know that excess bonus is reasonably good part of your total RA. Like if you calculate, I say 7 to 10% could be excess bonus if you are doing it nicely. Okay, so basically, I believe that the excess bonus was like part of FHO that family doctor are available to their patient. Not if suppose we are not available, patient will go to the walk-in. So ministry will not penalize us or will not give us excess bonus. So excess bonus means we should be available. Our access should be enough to the patient. And here, if suppose I have a capitation fee of 20,000 per month, according to what ministry says, 18.59 percentage of excess bonus they calculate. So approximately somebody is having 20,000, they will get every month 3,710 per month. But this is the ideal 100%. Nobody get 100%. So per annum it will be 44,529, which is never possible. Okay. Now, for example, if your bonus is like some amount and the patient goes and use outside service, that amount is deducted from you, from total amount, and you get less amount. So our goal is that how we can maximize, and what I am doing in my group, that we are calculating the percentage. For example, my 4,000 is potential, and if I'm getting 2,000, that means I'm getting 50% of excess bonus, and we try to maximize it slowly. Okay, so this is the methodology which I usually follow. First of all, everyone should know easily that how much is your outside use. And this is a complex process, because if you see outside use file, you need to click it, see it. Then if how do you know that 3 months how much they have used outside? I don't have any means like other than what we have created, that okay, how much they are using in 3 months. I did create a program 2 years ago, but it was not integrated with the OSCAR, so doctors were not using. But now we have integrated. Okay. Second thing is know your potential. How much you can get excess bonus? I should know what is my potential. So that is ministry give a figure, one number that, oh, this much is your maximum payment and how much you are getting. Then third thing is you must calculate that how much percentage you are getting. So we create an Excel file for our doctors and we say, okay, this is my potential outside use is this much and I am getting this much excess bonus. What percentage I am getting? And at the end of 6 months, I distribute to them. So I say, oh, this is 44.83 is this doctor's excess bonus they are getting. It is very important, and I have seen many times that if somebody has excessive use, we must de-roster them. I can give you example of one of my patient. He was having vitiligo and he was going for phototherapy, and that was given by a family doctor. And I got a $400 outside use. I was getting only maybe $20 is like capitation money. It was not worth keeping him in my roster. So, but many times we don't know easy way. So the idea, everything is that how we can see everything very easily. Okay, so this is if you see RA detail, you will see this non-LTC bonus, maximum special payment. They don't say excess bonus, but this is called maximum special payment. And here it says that 2,634. So this is the doctor's total potential every month, depending on that month roster. Now, somebody has used 1,249. So basically, the doctor is getting 1,384. But I know some of my group doctor has a negative excess bonus. And at the end of 6 months, we deduct some money from their RA. Okay, what are the challenges? I think there can be more challenges, but I see profile of patient. So some of the patient, whatever you do, they will go outside. Like some of my patient, they are so anxious. I'm opening 9 o'clock clinic and they go 8 o'clock. Oh, I had a very severe sore throat. I went to the walk-in clinic. How much extent? So those profile you need to understand. Urgency, if somebody is really urgency, you can't prevent them. Need medical help when away from clinic. If somebody, I'm working in Scarborough and somebody is Mississauga, they will obviously go. We can't stop them. There are many courts, many times in emergency and hospitals, our GPs or family doctor or a normal doctor billing, we still get outside use. We are fighting through the OMA, but still there is no like resolution of that. Poor access to clinic, that could be one of the reasons. There may be 2-3 more reasons, but I'm saying that these are the reasons. Patient goes outside and reduce our access bonus. Okay, so what we can do to improve access bonus? So basically, our group doctor should have a good after our clinic, and we advertise them, and then the patient has access. They understand that evening some doctor is available in emergency, we can come, and we should not go outside and don't use outside use or walk-in clinic. Locum during vacation, I highly recommend that if I'm going 1 month away, I should have a locum doctor. Then my patient, somebody is taking care, because I know that in my group, nobody else will take care when I'm away, unless until I have understanding with someone. And everybody is like, has so many patients, they might not be able to do. Keep some sports urgent appointments. So in my schedule, there are always 5 to 6 urgent appointments, which cannot be booked except the same day. So we are trying that, okay, if somebody call in the morning, my staff doesn't say there is no appointment available and you can go to the walk-in clinic. Improve refills and follow-up. A lot of patients just go for refills. So I'm trying to improve refills. Those are stable patients. I'm giving 1-year prescription, except diabetic. I'm trying to give rest of the people who are stable 1-year prescription. Educate patient. Many times I show them contract of my FHO that, okay, this is the contract you sign, and I do get a penalty or negative money from when you go to the outside. And many of them say, oh, doctor, we didn't know, and we will try our best. So educating patient is also part of that. Now, again, this is like, to me, looks like calculation, how many patients going outside, how much there is money, how much I'm getting capitation money, when to de-roster, when to re-roster. So this looks very complex to me, like a kind of thing that's mathematical diagram. Okay, this is just to illustrate that this is a RCP file, which usually I used to see. And most of the information I read, I used to keep on my cloud every year, month-wise, and then read it. This is the most tedious way. So we are trying to avoid this. Okay, so this is a complex system. Every month you have to see your RCP file, how many patients is rostered, who is using outside, time consuming. We are trying to be more smarter. This is what I'm trying to do. These are the few rules I'm trying to find out that if somebody is using too much use, like 10 times, 15 times, I immediately de-roster. My goal is that if their capitation fee 3 times, for example, 3 months, I'm getting $90. And if they are using outside is more than 3 times, I will immediately de-roster. Again, there is a gray area, which is individual to individual, I decide. And if I am in doubt, I can watch for next 2-3 months. Okay, so basically what we have done, I was frustrated, multiple clicks, calculation, CRP file, time wasted. Many times I don't have time and then say, okay, I will not do it. Many times my patient was accepted or rostered by some other doctor, still I don't know. Many times when I bill at the weekend, 288-2012, and I'm not being paid, then I come to know what's wrong, why I'm not being paid, and they have been rostered to someone else. So we have done some innovation and integration, and because of so many frustration, we designed some program. Okay, so how the technology work? There is a simple plugin, which is Chrome plugin, and it is stay in your OSCAR. Like you can add any extension in the Chrome. So this program is outside and it integrate with your OSCAR. And usually we need XML file, which is RCX file. Okay, so this is how basically the technology works. Our all RCX file and outside use file data are here in external server. And we load here. Now, most data is here, but then it can integrate through the API. API is basically application program interface. So like, for example, I want to de-roster the patient, I will do from here, but in my OSCAR, it will de-roster automatically. it will get the data, details, everything, master demographic, billing, everything we do through the API. So basically, I'm sitting every day in my Oscar and I can do anytime. Let me show you next screen. So this is my screen. If you see on top, the yellow arrow shows outside use. Once I click on outside use on my Oscar setting, I can get my Oscar outside use. Second thing about validate health card, because ES2 error is very common. We have done lot of things on health card validation, and first time we have done that health card validation, we are showing the number. I believe that I did not know for last 10 years that what is the importance of these numbers, and now I know and I have done. So here I have shown that 5150 I will be paid, but 53, 52 I'm not guaranteed I will be paid, though it shows health card past validation. Card is expired, but it's still, I know sometime I'm doing after 3 months my billing and I will not be paid. So I always tell patient, if 50, 51 code, I will see them. If your code is 53, 52, you must go to the Ontario service, renew your card, because I'm not sure I will be paid or not. And we have done some other thing, but that is not the goal today. I showed that this is the simple button. When we click it, what will happen? So let's go to the next. Okay, when I click on that button, which is on the Oscar, which is integrated with Oscar, I will see this screen. And you can see that I'm seeing that these patients, how much capitation, how much outside use, how much is the difference. And then I can manipulate and decide which patient I want to de-roster. And second thing, if I click in any of the patient, I will be able to see that, oh, this patient has gone on 14th of April, A007, on 1st of May, K131. And we are trying to calculate in 3 months, because the goal is that I can de-roster 3 months and get that money back if something I find positive. Here, I can have access to their demographic. I click here, I will be able to see my Oscar demographic. And here what I do, like for example, you are seeing 17, which is my FHO code. I want to turn it to my normal fee for service. Once I do it here, it will automatically do in my Oscar. I don't need to go anywhere. From here, it will be doing. There are few other things I have given, that how much maximum bonus 3 months you can get, how many rostered patient you have, how much outside use, how much balance. But since already I have de-rostered many times, so my maybe number is not so correct. There are two more buttons I have given on left side, de-roster. This is slightly cut off. And there is a termination. There are termination first and de-rostered. Okay, next go to the next screen. Okay, so for example, as I said, if I want to convert from my BACH to my fee for service, when I click here, it will say roster enrollment status updated successfully for patient. So already in Oscar, my demographic, everything is changed sitting here. Now, if I go to my termination, like de-roster list, then I will see this screen. And for example, the same patient, I have hidden the name of the patient here. But for example, you see that I have not billed. So I have to do two things. First of all, in my Oscar demographic, I need to change that now the patient is fee for service. He is not rostered to Ministry of Health. And then I need to bill from here, bill in Oscar by black circle, that 402. Automatically, it will select your date and 402 code, and you can bill very quickly from here. Okay, now what I have done here, that, okay, the question was that if we keep on de-rostering, our roster size will decrease. So there are two type of patient which I want that, okay, do not roster. As I told that whatever I do, they will not understand. Those kind of patient, I say DNR. And if I say that this patient is good, probably I can teach them, or they are agreeable to my thought that next time they will try to only go in extreme circumstances. Then I put here note RR, okay? So at some point I can re-roster from this system. these are the some termination code, and for example, you get various termination code. Let's see here. So for example, if I see in my RCP file, I say 91 code I saw for 10 patients. There was one patient code, termination code was 40, and one patient termination code was 74. So basically, I don't know 74, then I see here what are the reason. For example, 74, no current eligibility. 91, patient roster with someone confidential, you don't need to talk to them. So here I can see that my patient who has been terminated, obviously this patient, either I talk to them or my system should show termination. So from here, we can terminate the patient also. Let's see another screen. Okay, 1 second. Okay. Okay, this is the screen where here is the MCD data on the right side and left side. There's a like I can see, and if I click on terminate, then in my OSCAR, it will be terminated. So this is different than derostering. Derostering means still I have a doctor-patient relationship. But here, because these people have signed with somebody else or they don't have eligibility, that's the reason I'm terminating. So we can terminate also. So most of the functionality everything we can do from here. This is how I can get detailed lot of patient like this. One of my patient, I see that she was bedridden. Some doctor visited her at home, and a lot of outside use was there, so I derostered her. I can see capitation amount. She was a good patient. Every month I was getting approximately more than $55, but due to her personal situation, she was using a lot of outside use, so I need to deroster. But this patient, I could re-roster again some point of time. Okay, this is the basically your front staff has to do on these simple tasks, that these two files you have to upload in the system, and then everything you can see from OSCAR. This is what making the system more efficient. Everything analysis is done. How much 3 months they are using outside use, how much capitation they are like we are getting, and then you say, oh no, this patient is not worth, you can de-roster. And if you feel I want to re-roster, you can put a note that re-roster. If you say this patient is useless, how much I educate, you don't re-roster them. Obviously, I understand that with a lot of screen, I may still not be able to explain everything, but I am putting an exhibition booth in Ontario MD Digital Conference on 18th and 19th of September. We might be able to show you some live data there. Okay, so the idea was this: with the less click, less work, we can work more. Admin staff, which anybody can do, my admin staff very easily load this 2 file every month, and then anytime sitting at my OSCAR, I can click on outside use and I can see. And XML file is very hard to read. PDF file, RCP file you can read, but then to transfer every data into the OSCAR is very tedious. Okay, so this is basically my idea that we want to maintain our roster size. So 3 times we can do something, deroster, re-roster, something like this. But the goal is that obviously this is a calculation, but I want to maximize my bonus. So I'm derostering, and when it is a turn, I re-roster them also and get some money. Okay, so this is what I said, that if my roster size is decreasing, obviously some of the good patient I can re-roster. So here, green circle, I have written note that re-roster, RR means re-roster, sorry. Here, RR means re-roster. This patient I will re-roster. This red circle, do not re-roster. I put just only DNR. I will not re-roster. So here I can easily again re-roster them. Here there are 2 buttons. I can bill again like 200, and demographic if I need some more information. Otherwise, just I can bill from here. Okay. I think people are coming late, but we are almost to the end. Is anything somebody know the wrong time? Did we put wrong time, Riddhi?
No, it was 8 in the email.
No, doctor, it was 8.
It was it. Okay.
Mhm.
So I think some people are joining 8:30. What I'm trying to say, Dr. Salma, that it's too complex to read data from something system. And the second thing is that every complexity we kept outside of the OSCAR, everything worked through the API. So in demographic and billing, these are the two parts we work through the API. And I think OSCAR Pro, it does work very well. I'm not sure about Juno and
Mhm.
Everos, but if you could want anytime, we say 3 months we are trying to give you, you want to try, you can ask us, we can integrate the plugin. Your staff will do uploading the file. 3 months file you upload and you will see that magic start happening. The biggest thing is integration because I am sitting every time on my OSCAR and I can analyze my data. And these are screenshots from my program. Okay, so we have done a lot of other things through our OSCAR plugin. Probably I was motivated through Cortico. I think Cortico was a similar one. Dr. Kensington Clinic in Vancouver, they started. They took a long time. We did in shorter time. So our unique health card validation by the code, I will still say that out of the 10 family physician, maybe 6 or 7 doesn't know what is meaning of the, they just see health card pass validation means they bill it. And I'm sure I can guarantee you that some of the billing will not be given to you. ES2 error will come. Because normally every doctor doesn't bill immediately. Sometimes we bill up to 3 months. That is the window time. We also develop a patient secure messaging, which can attach the file. Like, for example, I am trying to involve less my front staff when like blood report, ultrasound, I send directly the patient message and what tickler I'm writing, I write. And in fact, I have a template. Okay, your blood work is excellent. You don't need to come. I will discuss this next week. This is a simple thing. Patient get their blood work and get a message also. So secure messaging system also be developed. Now, other thing that we have done a lot of things for my clinic because to reduce front desk staff. For example, a patient comes and say, doctor, my email has changed, my address has changed. I say, okay, go to the front desk. We put a touch screen. They put their details and they can update everything. And my OSCAR, all their address, email, phone number, everything they can update. New patient are coming, they can register everything. Once it is approved, my front staff by one click, the data goes in OSCAR. So if some walk-in patient coming, new patient coming, we do. We also made similar to Ocean Form some of the forms. And the forms I'm using with the Heidi template. So like my daughter is a family physician and she's doing Well Woman Health Clinic. And we put a form. Now this form I put in context of Heidi and there is a template and her consult letter is automatically everything is prepared. We are doing that. So we have certain forms also. Our online booking, Dr. Rubia, I think probably you are very late. Your end. Okay. So my online booking working very well, and I'm very happy that it is reducing my front desk time. One of the time the challenge was that our phone line was very busy, and I was not able to solve anything. Lot of patient complaint, and now my patient are booking online, and I'm teaching them. Every room there is a QR code. If somebody come, I give you example. There was a lady who is working in a like a company like a labor. She says, "Oh, do you have a smartphone? Yes. Do you use email? Yes." Then I said, "Why you cannot book for, like online appointment?" I taught him, and every time she's booking. Access bonus, the one which I showed you. Uh, Similar part, I am sure that roster management easy way is one of the things because I saw last OMD digital conference and I attended some of the things where how roster management was being done. I said it was very time taking. In my system, my roster management is easy because my report by template, if I say, okay, my provider number 17, which is associated with my FHO. I say, oh, this much patient are rostered. How many patients are not rostered with the ministry? I check with another provider number, but I had to keep 2 provider number in my OSCAR. We also making terminal self-check-in in our clinic, where somebody patient come, we don't want to be crowded in front of the our front staff. So they check in, they can sit in waiting room, and then my staff will call. So there is no crowding in front of the lining system. That is one thing. We are also working on queuing system. So for example, my lab is so busy on Saturday, like 20 patients sitting, they don't know what time they have to wait. We are still developing queuing system. So everybody knows that, okay, my token number is this, we don't want to display name, and how much my waiting time. Suppose my waiting time is 1 hour, I can go have a tea or something outside and come back. So we are doing something which I feel happy, and we are trying. I'm the doctor who thinks that I'm thinking goal oriented. For example, I say to a depressed patient, what do you want? You want to be happy? It's not necessary that how I can make you happy. So I ditched Oscar Pro, and we are currently on my own Oscar. But the thing is that a simple thing I want to do, I can do. Like, for example, in my demographic, I said prefer phone number should be different color. I could do with my own programming staff. Can you do this? And within 1 day, he did it. So a lot of things which according to my use, I want. And as a doctor, I want that what are things to be done. So we are not certified by OMD. I think at some point I may go for OMD. We have a user interface improvement, API ready. We are developing so much API. In future, we might develop API. For example, my patient say, like e-chart in like our hospitals, they go and they can see their reports. Probably at one point we'll be integrating something so they can see their report. We have all lab integration. We have already done for Life Lab, Alpha Lab, Med Health Lab. So my Oscar currently, all lab we are getting. Inbox management, we have already done by AI. I think 80 to 90% of my faxes are like the front staff has not to do anything. They are flagged to the doctor. They are like a type of record document it can make. Description also, there is some error. Then we have a system where I can give feedback to my AI programmer that, oh, this is something I'm not happy, you need to do like this. But I believe this is the future, because AI will do more better job than my front staff, because front staff sometimes keep on rotating, changing. They will different type of description they will put. But AI is one person. No, once you teach the AI, it is one person which is working for you. Computer are great servant. I believe that computer are very good for me. We can provide, if anybody is interested, on local server as well as on cloud, our Oscar. Again, I would like to say that my goal is not commercial. I am close to my retirement, and I just want to be happy that how I can improve doctor's life. If you have any wish list, we will try our best to help the doctors to take them, make it in real life. There are every day we have a complexity of life and how we can improve it. So we will see you in exhibit booth on digital conference of September 18, 19. We have a small booth and we'll try to show to the everyone that what we have done. If you need my help about roster, we can take another seminar. But I think if anybody is interested and want to see live what we are doing, they can come to my clinic. My clinic is Maple Clinic at intersection of Markham and Ellesmere. It's a big building, me condo on the ground floor. We have a good office. I think we have a very good office and very well designed, and anybody most welcome to see if they want to see anything in the live. I know that some of the participants were a little bit late, but I have made a recording and I'm sure that I can provide recording to them.
Oh, hi, Dr.
Any
Dhawan.
question?
Sorry.
Yeah.
Sorry, I got late. Our previous meeting was supposed to finish at 8, but it went on, so I joined late.
That's okay.
If you have the recording of this, I would like to.
Yeah, so this time I'm recording. I'm sure that I will be able to give recording to them, to everyone, unless until there is a technical glitch. So I have recorded this program and hopefully I will be able to give the recording.
So my question was, you mentioned about that because I use Avros, which is like Oscar-based software. So you mentioned there is a plugin which we can use, and it will tell us about improving our access and re-rostering which person to re-roster, and that's one I was interested in. And if that will be possible under Avros, or we have to.
Yeah, so I'm not sure my programming team can take and see that whether it can be. So outside use everything you will be able to see in our program. That's not a problem. But if you want to integrate, for example, by one click you want to deroster, by one click you want to bill, they need API. And API is inbuilt in OSCAR Pro. I'm not sure Everest Pro, but we haven't worked. If you give access to OSCAR like Everest, we can tell you that whether we can hit API or not. Nilanj, can you tell something more?
Yes, doctor. If they can give access or something, or even if they sit with us or like share their desktop or something, we can help.
Who the owner of the Avros has to, because we don't know. Ours is it's the cloud-based thing. We just log into the system,
Yes. So what I'm saying, we just if somebody from you are sitting over computer or something and share screen, I can guide you to see that our software will work with the Avros or not.
Oh, okay, all right.
Okay, Dr. Kalra.
We have to see that whether we can integrate or not.
Okay, one more thing, Nilanj, I'm adding. Dr. Kalra, the thing is that Avros, Juno, and OSCAR Pro are basically OSCAR. In OSCAR, there is a file called OSCAR properties. And in OSCAR properties, we have to change that they can accept API. That is the first thing is required. And second thing is required that your program has endpoint. Endpoint means when we send a request to your computer, is there is acceptance or not? They understand my request or not? Most likely you might have, but Avros also is like a closed kind of thing. They're like online programming. They're not sharing with anyone. So I'm not sure. So there are two requirements. You need API endpoint, and in OSCAR properties, we need to enable that we can enable REST API. This is called REST API. But we can check and tell you.
Okay, sure. I know because you are making so many changes and everything like that. We really like that. And it is easy, right, to switch if you wanted to, or like from Avros to your system, or we are stuck with in case,
Okay, so there are two challenges. One is your vendor, how when I was getting out of OSCAR Pro, they gave me a lot of problem. So if you have time, I can tell my story. So when I asked them, they gave me a 7,200 bill. And anyhow, I wanted to get out. I paid by my credit card. Now they were giving so many ifs and buts. They say, no, you are not vendor. It will be not safe. They were not giving me test data. So most company will say you need a test data, and test data is that there is a 2,000-3,000 extra money. Okay. So if you don't get, so anyway, I complained to Ontario MD and I said that OSCAR Pro is not giving access to me. They charge me 7,200, which is like extortion of money. And within 7 days, OSCAR Pro refunded my money, full 7,200. They credited my money. Once I complained to MD. After that, yes, I know that my contract was up to February. And then I was asking, they were not giving me test data also, because test data, we can match the data between two OSCAR and then it is much easier. So they were not giving. Anyway, I got a SQL dump, which is much easier. And SQL dump is easiest way to get your data back. And we did not pay much amount for them. And I sit with my Nilanj and 3 days. So I took a data on 23rd evening, 24, 25, and 26. So 24 was like holiday, and 25th was Christmas Day, and 26th was Boxing Day. We worked hard and we transferred every data. Now we do have experience. I probably think, yes, it can be done. Again, there are minor challenges to this. Unfortunately, I wish that anytime we can transfer data from any system. Suppose I want to go TELUS PS Suite, I can go. If I want to go Accuro, I can go. But reality is not that true.
Yeah.
It is very hard. And all these vendors charge a lot of money.
Yeah. Yeah. Thank you.
So I have a question, Dr. Dhawan. If you
Yeah,
don't
for
mind.
sure, for sure.
My question is, actually, there are two questions. One is a request, rather. If I could also get a recording, I would like to share it with my 4 colleagues to see if,
Okay.
to get their input.
Yeah.
Basically, we would be, if and when, but, we would be looking at the Chrome extension and the API to improve the OSCAR billing. I know that some of my 4 colleagues are looking to change their EMR, but see, the non-MD certified EMR, you don't get HRM reports, right?
Yeah, so there is a
So
big
that's a
challenge.
big thing. It's a big challenge. So, but at least, so I think, the thing, if on our agenda, would be to know more about your extension. So if you could send it to me, and what will be the next step if my 4 colleagues are interested to know more? Because some of them are paying the, doctor care to manage their access bonus, and they are complaining that, that it is expensive. I don't know how much would be the charges if we use that Chrome extension.
Okay, so are you using any online appointment, health card validation, secure messaging, anything you are using?
We do use the Juno integrated. I like to use, Oscar and Juno. I don't know about Avros, but Oscar and Juno are basically 2 sides of the same coin. And we can, at a touch of at clicking a button, we can actually change our interface
Send a message.
back to
Send a
Oscar.
message.
No. We can actually change our interface to actually the Oscar interface. The Juno interface is just a little bit different. They have arranged things differently on the screen. But all the previous, report by template, all that stuff, it still works that, I had acquired from my Oscar days. It still works with Juno. Unfortunately, when I moved to Juno, I think a year after, Juno was bought by Well, so it was back to square one for me. But so yes, we do use health card validation, and we don't go for the codes, but we go with the description. And if the description says that, like it comes in with a red flag,
but you need to click on description.
No, it actually comes, or there is a red flag there. So we always tell the patients that yes, they have to get the necessary things done by the Service Ontario before we can see them. So that's taken care of. But yes, if that extension and the API works, it will be a lot less hassle, I would say.
Yeah, for sure. We want to work with you people, and we are not looking that, oh, this is only a money part. We want to understand that more doctor can use our system and understand the value of the system. So there will not be any charge. We may give you 3 months free to try and see that how the things work. We always want feedback from you people and see that what improvement we can make, because always there is a scope of improvement. feedback is
Definitely,
important.
definitely.
Yeah.
Yeah,
So we
yeah.
are open to that. So
Mhm.
what I will do, I will share your screen recording, and believe us that Nilanj will be point of contact and he will help you to
Mhm.
understand. And
Mhm.
till you say that, doctor, we do find value in your system, we don't charge you
What do you
any
mean by
money.
that?
Okay, so at some point, like a plugin
Mhm.
will be you had to pay because we need to
Mhm.
pay, like
Mhm.
our
Mhm.
system data is on
Yes, yes.
cloud or whatever.
Mhm.
Okay, we
Mhm.
are saying 3 months you will be using it, you will testing it, and if
Mhm.
you find that it can be, you are open to, if you say your group of people want to come to us and want to see our Oscar and any other thing, you are most welcome, because every time we are looking for something better. No, if you
Mhm.
go to the food, you say, okay, this pizza is
Mhm.
better, I want to eat that pizza. So I'm not saying you can always see us, but let me send you a recording and we will be in touch with you.
Right, let's do that. Let me see, what's the level of trust with them, and then I will get back to them. But usually, whenever we meet, they want to have further information about the next steps. And I do understand that, of course, with your fair work, you should be fairly compensated as well. And
Yeah.
yes, the 3 months, of course, makes sense, and I really appreciate it. But going forwards, because if some of the doctors are using doctor care, they need to compare, like what they're looking at in terms of charges if they change from doctor care to this one, because I believe their main reason would be to optimize their access bonus. And so that is why I needed to get an idea about charges going forwards after the 3 months. But we can always discuss it over the email. That's no
Okay.
problem.
Can I say one sentence to you?
Yeah.
Because I'm the user of Doctor Care, and
Mhm.
they will tell you that, oh, this is a capitation money. This much you will get if you de-roster them. But your process is not integrated what we have done. This is how it is being done. Do they do everything for you?
I don't know. I don't use doctor care. I've never done
Yeah,
that.
but I know because I have
Uh-huh.
used Doctor Care also.
Mhm.
I have
So what do
used
they say? What do they say?
no, they will send a PDF file to you and they will say,
Mhm.
oh, this patient has been using outside use this much and this capitation this much. If you re-roster on such and such date, you will get this much money. They give a
Okay.
report.
But they don't do so. Mhm.
They don't have an integration. So basically,
Mhm.
they are
Mhm.
closed loop. Their program is closed loop.
Mhm.
Closed loop
Mhm.
means maybe whatever they are doing, but they just give you a PDF file which
Mhm.
tell you that what to do. That is good,
Mhm.
but again, it is not solving your whole problem. It's a partial thing.
Yeah, yeah, and as doctors, we don't want to blindly trust anybody. So if doctor care is telling me to do something, I would like to know the background. I
Yeah.
would
So
like to
here
validate
also,
that too. So we cannot validate that. This is what you are saying,
yeah,
right?
yeah. So here you have a full control that what you want to do. You
Mm-hmm.
only see everything,
Mm-hmm.
and you can
Mm-hmm.
de-roster, re-roster, and
Mm-hmm.
bill for everyone.
Right. Okay, so please send me
Yeah.
that recording, and if you don't mind, I will be send. Can I share it via email to my 4 colleagues? Is it
Okay.
okay? Right?
Yeah, for
And
sure,
then,
for sure.
if there is interest, then I will get back to you guys. Okay?
Okay. Okay. Thank you
Okay.
very
Thanks
much.
very much for your
And
time.
thank you for joining.
My pleasure. Thank you. It was a
Okay.
very
Bye.
productive
Okay.
presentation, though. Thank you. Take
Yeah, I'm
care.
sure
Bye-bye.
because I was frustrated along, like I'm frustrated for 2, 3 years. And then
Yes.
I
Yeah. Yeah.
said,
Yeah.
we need to integrate. Integration was the biggest thing we
Exactly.
achieved this time because before we
Mhm.
did, but it was
Mhm.
not integrated. So integration is one of the things. Thank
Mhm.
you.
Yeah.
Okay, bye,
Okay.
bye,
Thank
bye,
you very much. Have a good night.
bye.
Take care.
Good
Bye.
night. Good night. Bye, bye. Okay, Nilanj. Malti.
Yes,
Dr.
doctor.
Yeah,
Malti.
yeah, I'm here, Dr. Dav.
So I think probably if you need help, Riddhi is
Yeah,
always uh, to
yeah,
serve you. Niranj is also there. We want to see your positive access bonus.
yes, for
Okay.
sure.
Okay. If there is anything I help you, please let us
No,
know. Okay. Okay.
yeah, thank you, Dr. Devan. Yeah,
Okay then. Okay then. Okay then. Bye.
bye.
Bye.